Hello and welcome back to This Week in Global Health, or TWIG. TWIG is a live weekly global health news roundup. We're broadcasting live over the internet, so if you're watching us live and you want to send us questions, thoughts, comments, pontifications, criticisms, anything you want, you can send it over hashtag TWIG, TWIGH, on Twitter, or go to our webpage, www.twighTwig.org, and you can send us comments and thoughts straight from the webpage. Right, this week we've got a lot to cover. We don't have an actual theme. We're going to be talking about HIV a little bit, talking about a few other things. I'm going to ask the panel members to introduce themselves. Right off the bat, we're going to ask Chris Ronson, who are you, where are you, and what are you going to talk about today? And Chris, you're muted at the moment.
I'm starting off really, really strong. Hi, everybody. I'm Chris Ronson. I'm coming to you from San Francisco, California. And today I'm just going to be doing a little bit of an Ebola update on Nigeria and a publication from The Lancet and the Globe and Mail.
Okay. You see, that's evidence that this is a live show. There's no post-production editing. Katie, talk to us. Who are you? Where are you? What are you going to talk about today?
Hi everyone, my name is Katie Jackson. I'm coming to you live from Stockholm, Sweden, and today I'm going to touch upon a Global Health Lancet article talking about decline in mortality around the world and a logo competition for AIDS 2016.
Thanks. Okay, and Emily, talk to us.
Hi everyone, I'm Emily Lentinello and I'm coming to you from Toronto, Canada, and today I'm going to talk about the Global Health Watch, a world alternative health report.
Emily, you pronounce Toronto with the second T. I've never heard a Canadian do that. It's usually
our
Toronto.
audience is international, so if I just say Toronto, people might not know where I am.
We don't like pronouncing our T's.
No.
This way, we don't really believe that you're a Canadian. You know what I mean?
I promise. I'll bring my birth certificate next week.
Okay. All right. And, of course, Sulzan, coming to us from India. Talk to us, Sulzan.
Hello everybody, this is Sulzan and I'm speaking to you from New Delhi, India. It is 30 minutes past midnight here and I'll be talking to you about antibiotic resistance in India.
Okay, thanks very much. And we've got a special guest on tonight, Rachel from New York, DNDi. Could you just tell us a little bit about who you are?
Sure. Hi, everyone. I'm Rachel Cohen. I'm the Regional Executive Director of the North America Office of the Drugs for Neglected Diseases Initiative, which is a not-for-profit research and development organization that develops needed drugs for neglected patients.
Okay, and today you're going to be talking to us a little bit about pediatric
HIV.
Brilliant. Okay, that's going to be exciting. So stay tuned, everyone. We're going to jump right in. Katie's going to give us a science update. Over to you, Katie.
Perfect. Okay, so last week we talked a little bit about the new UN AIDS report with its ambitious targets for HIV. And so next the question is, well, how can we anticipate whether countries will meet these targets? And a paper just came out from the Lancet Global Health looking at rates of decline in child maternal HIV and TB-related mortalities. And this is different than just looking at numbers of deaths or levels of mortality, and it's important because it shows the rate at which, how quickly or not, countries are making progress in reducing mortality. It can also be used to get a better idea of what can be expected from countries in meeting health targets and development goals. So when we set these goals, we can understand how quickly they can be met. Using this metric, the authors found that most of the countries are on target to meet HIV and TB mortality decline rates, which is fantastic. We still have a little bit of work to do, though, on maternal mortality, as we're really off on our rate there.
Okay, so if I understand you correctly, we're now, the metric here isn't just where we're at, but it's where we're going and how quickly we're going to get there.
Yeah, exactly. It's over a time period, so we understand what is a realistic goal. I mean, it's silly to set unrealistic goals, and then we can look at it that way.
Okay, thanks very much. Now, Emily's going to talk to us about the Global Health Watch, and I'm sure a lot of you have come across this before, and I certainly have come across it many times, but never really known exactly what it is. So, Emily, could you just give us a quick update? What is Global Health Watch?
Sure. Well, the Global Health Watch is it's in its 4th edition, so it's a book, it's literature, and it was developed over 10 years ago now, actually, by a group of professional people who work in various aspects of international health who weren't very happy or satisfied with the information they were getting from documents such as WHO reports. So they decided to create something that was alternative, both in terms of content, but also in terms of the way it's presented. So the idea is that it's not just for people who work in international health or in academia, for example, but it's for anybody. So anybody who's interested in what's happening in the world from a health perspective can pick up the Global Health Watch and be able to understand and read what's going on.
Okay, and I believe it's sometimes referred to as the Alternative Global Health Report. Is that right?
That's right. I mean, and as it says, it's alternative in the sense that it's an alternative to sort of more official or reports or documents such as what the WHO
Okay,
would
and
produce.
some of the time, does it like basically fly in the face, or kind of almost contradict some of the standard party lines that are out there?
Right. I mean, the goal of it, as in the title, is watch. So the goal of it is to absolutely provide a forum to criticize or to speak of social justice or sort of more watching. So looking at sort of big agencies such as WHO, Gates Foundation, whatever it may be, to criticize and to look at it from a different perspective.
Right. So
So I
hold
just
them
want
to account, essentially, right?
absolutely hold it to account and also shed light on countries. The report itself is a collaborative, internationally collaborative report, so people from all over the world contribute to it.
Right.
And I'll just let you know that if you want to look at any of the editions, including the fourth, which is just out, you can go to ghwatch.org, and all of the information is there, including launch information.
And we'll put a link to that in the show notes as well. Chris, you had a comment.
Oh, I was just going to say, so you, like you just said, released Global Health Watch 4 recently. Is it an annual publication, or how frequently can people expect updated editions?
It's not annual. It'd be great if it was, but of course lots of work goes into it. So the first publication came out in, I think, 2005, and so now we're in 2014, and it's the fourth. So it's usually about every couple of years that one is produced.
Okay, interesting stuff. Well, I look forward to having a look at that. Next up, Sulzan, you're going to talk to us about antibiotic resistance.
Absolutely. So there's a recent study in Lancet which came out and which said that there were 58,000 neonatal deaths last year in India due to antibiotic resistant strains. Now this is really important because, and very interesting, because India is lagging behind in its Millennium Development Goals for improved sanitation and relies heavily on the wide use of antibiotics due to absence of sanitation. Now, we've all known that unmonitored use of antibiotics in humans and lack of sanitation are all, selectors for antibiotic resistance in bacteria. However, what is also very interesting is that we are seeing a steady rise in antibiotic-resistant infections worldwide, including in developed countries, due to abuse of antibiotics as growth promoters in industrialized farming. In fact, there's another recent study which came out which talks about how 80% of antibiotics in US are used on factory farms for industrialized farming. And according to CDC, last year, 2 million people in the United States were infected by antibiotic-resistant strains, resulting in 23,000 deaths, which, according to a recent study, cost U.S. healthcare system in excess of $20 billion.
Right,
As a result,
right.
Yeah, I mean, and also
antibiotic resistance is still a problem. It's a problem that's worsening, and it's a problem that's expensive. So obviously this is something we need to address. I mean, we've always known that it's an issue, but I think, the news item here perhaps really is this. The problem is maybe bigger than we thought. Is that perhaps what 58,000 neonatal deaths in India alone? That's certainly perhaps a bigger problem than I had appreciated before now.
Absolutely, and it's a problem which is rising, and there's a growing number of studies which are now linking it to industrial farming as well, not just abuse of antibiotics in humans. I mean, considering that in developed countries there are regulations to control abuse of antibiotics in humans. So there are show links, and in the show links I will be definitely putting a reference to these two studies that I've mentioned so people can know more about it.
Right. Okay, I think Katie had a comment.
Yeah. Joel, just to say, I think that it's also becoming more important as we become more and more resistant. So whether it was just lack of knowledge before, we now have like XCR and all these different types of tuberculosis that are resistant to more and more of the spectrum. And so that means more and more development into drug systems. And we have to think about drugs differently. We have to go around it a different way because the way we're going at it, we've created all the drugs we can think of, and now we have to be a little more creative now that these diseases are learning to adapt to them.
Right.
Absolutely. And
ultimately, sorry.
Another really interesting point, Greg, here is that there are no new classes of antibiotics have been discovered since 1987.
Yeah, I mean, the real key to sort of antibiotic resistance management is the way we use existing antibiotics, right? So, I mean, part of the solution is we need to develop more drugs, but really, as clinicians, we need to be much more circumspect about what antibiotics we use and when. We need to use them when they're indicated and not just dish them out like Smarties.
And better diagnostic tools.
Yeah. Okay, so now we're going to go on to the next part of our show, which is going to be an interview, or we're just going to ask for a couple of comments and thoughts and some wisdom from New York, DNDi. Rachel, we're really delighted to have you on the show. one of the things that we know is important, but I want to ask you a little bit about is the coverage gap between adults and pediatric ARVs, for people with HIV. Could you just give us a little bit of a nutshell? Why is there such a big gap?
Yes, well, UNAIDS just came out on World AIDS Day with a new report estimating, of course, that there are about 35 million people with HIV. Globally, roughly 13.6 million adults today are receiving antiretroviral therapy. And that represents about 38 or 40% of those in need of treatment, which is actually a little bit of a decrease from previous years. So that's one set of questions that could be asked. However, for children, we've seen really that they are lagging far behind in terms of access to treatment. So less than 1/3 of children with HIV are actually receiving antiretroviral treatment. And there are a whole host of reasons for that. Some have to do with challenges around antenatal coverage in rural health centers, testing and treatment of pregnant women, unavailability of diagnostic tools that can detect HIV early in infants at the point of care. But one of the most challenging reasons is that there really are not appropriate and age-adapted formulations of antiretrovirals for children. And this is especially the case for the youngest ones who are at the highest risk of dying without treatment. I'm sure everybody knows that 50% of children with HIV will die before the age of 2 if they don't receive treatment, and 80% will die before they turn 5 years old if they don't get access to treatment. So this gap is truly unacceptable.
Right. And that's interesting. And I used to work in pediatrics in South Africa, and I had a lot of patients with HIV. But in those days, obviously, we didn't have antiretrovirals to give children. And of course, one of the big problems as ARVs were developed was that pills were too big. They weren't the right. There were too many of them. They didn't taste good. These are things, if I understand correctly, that DNDi is actually going to great lengths to try and address. Could you talk to us a little bit about that?
Yeah, absolutely. We're going to be, we are already, have been working since late 2010, early 2011 on developing an improved first-line therapy for infants and young children with HIV. In June 2013, the World Health Organization issued new guidelines which basically say that any child under 5 years of age needs to receive immediate ART, regardless of their immunological, virological, or clinical state, meaning regardless of their CD4 count, their viral load, or even how they present clinically. And the other recommendation is that for children who are less than 3 years old, WHO now recommends that they receive a protease inhibitor-based first-line therapy, whereas that has not been the case previously. So today, what we really need are protease inhibitor-based first-line therapies that are adapted for infants and young children. As you say, the formulations that we have today, especially for that protease inhibitor, which is a ritonavir-boosted lopinavir, we sometimes know it by its brand name, Kaletra, tastes terrible. It's in a liquid form. It's requiring refrigeration. It's very heavy and difficult to store and carry and so forth. So what we're going to try to do, or what we're doing very, very, very actively today with our partners, is to develop a solid or granular formulation that will all be in a fixed dose so that children will have available to them a ritonavir-boosted lopinavir with abacavir or 3-TC and or ritonavir-boosted lopinavir with AZT and 3-TC, as well, I should say, as a standalone ritonavir booster. This is getting a bit technical, but for those children who are co-infected with tuberculosis and they will need a little extra of that ritonavir boost in order to overcome drug-drug interactions with TB drugs.
Right, that's very interesting. And so you really are talking about like a sprinkle. If I'm envisioning this correctly, you've got like some kind of fixed dose combination that you would sprinkle over the child's food. Is that right?
Right. I mean, it's gone from being called sprinkles to granules to mini tabs to pellets. I don't know what the correct term is today technically, but we'll call them pellets. And the idea is that they'll be in a capsule, and you can spread that over food, let's say any kind of food, or for the really young babies, you can put it in their mouth before putting them on the breast.
Okay, interesting stuff. Well, thanks very much. Super interesting, and we're going to hear more from you during the discussion section of the show in a little bit. So if you're watching this and you're interested to know more, don't go away. Stay tuned. We're going to hear more from Rachel in a second. Right, Chris is going to give us an update on Ebola. Chris, over to you.
Thank you, Greg. Just to give everyone, like we said, an update on Ebola in terms of Nigerian Ebola care. Nigeria, in one of our early episodes, we commended them, as we did the rest of the world, for containing their Ebola epidemic very quickly by treating it as an emergency almost the moment that they became aware of it. So now it's been because they delivered hospital care for people infected with Ebola and managed to reduce the 70 to 90% mortality rate down to about 40%. This last week in articles by both The Lancet and the Globe and Mail, they're sort of highlighting that one of the keys to improved survival is A, quick intervention after symptoms begin, and also keeping patients hydrated and maintaining electrolyte balance. These measures fend off the cascade of internal failures typically caused by the virus. And the Lancet takes it a step further discussing parenteral administration over oral rehydration. One of the challenges with oral rehydration is that when Ebola manifests, it causes nausea, vomiting, and diarrhea, which also cause profound water and electrolyte depletion, as well as low fluid volume, which leads to circulatory collapse and eventually death. Administration of parenteral fluids seems to circumvent a lot of the issues with the vomiting and is a proven treatment for dehydration that cannot be managed by oral replacement.
Okay, and for those of you that aren't familiar with the term parenteral treatment, basically means putting up a drip, right? So you take a bag of fluids, you stick in a needle in the hand, and you run it straight into the vein. Okay, and clearly that is preferable to
more direct
oral fluids, especially if you're vomiting, right? Okay, very good. Now, what we're going to do is we're going to end the part of the show that people watch on YouTube. So if you're watching this on YouTube or you're listening to the podcast, thanks for watching. We love you guys. Come back next week, same time, same place. We're going to carry on. Next week, in fact, we're going to have highlights from 2014. So we're going to talk about all the biggest stories in global health over the year that we've seen over this year. Just remember that we've got a podcast. If you're into podcasts, listen to us there. We've got a webpage, twig.org. Go there if you want to read our blog, etc., etc. Until next week, don't ever change. Don't do drugs. Always do your best. And if you're that way inclined, in those circumstances, remember to use a condom. Being December, AIDS month. Okay. Thanks everyone. We'll just so that'll be the end of the YouTube show. We'll now go into a section of the show that's a little bit more laid back and have questions and answers or discussion. Chris, do we have any questions from the audience on Twig, on Twitter?
Thus far, we do not, but actually I know that Sulzan had sort of a follow-up comment to, I believe it was on the Nigerian Ebola rehydration situation.
Yeah, sorry, and Sulzan, just to let you know, sorry, I did see that you had indicated that you had a question, but I just wanted to kind of keep us in time there, and then we'll go into a discussion now.
Absolutely. I just wanted to quickly mention that the New York, so Times has now, the Times Person of the Year has been chosen and is the Ebola healthcare worker.
Yeah.
Which is great. I mean, in terms of, the impact, and people are realizing the importance of healthcare workers, and I think that's going to do wonders for recruitment of healthcare workers as well.
Nice.
Yeah. The sort of PR and support.
Yeah, I think it's a really good point as well, because I think that has come up in the early stages of Ebola. We realized the most at risk were the healthcare workers. So I think that's a really good initiative for Time to really commend them. They're the most at risk, and they are always in the line of fire. Especially in this epidemic, it really showed the need for stronger health systems and the equipment that is needed to protect healthcare workers, as they're the first ones to get hit with anything.
Yeah,
absolutely.
Without question.
And also, considering them, making them heroes, and it's like having someone who's who's a firefighter. It's that kind of situation. I think people are going to now look up to them and as heroes, which is great.
I think they did an Instagram or a hashtag campaign, excuse me, about that, about holding it up, being like thank you or whatever, and there was a campaign about it to thank all the healthcare workers. So I'm glad they're getting the recognition they deserve. It's not an easy job.
All of the different MSF field offices would take pictures saying we support you from Sudan, and we support you from our offices in France, and so it was just really neat, that collective support.
Yeah, no, that's terrific. Now I have a question for Rachel about DNDi. So could you just talk us through a little bit about how it is that DNDi develop new drugs for neglected diseases? Is it similar to a pharmaceutical company where you've got sort of a discovery phase and then a pipeline and then registration and IP stuff, and then or is it more kind of working with a range of partnerships and connecting in with existing pharma companies? And so could you just talk us through a little bit about your sort of your business model in a sense?
Yeah, absolutely. It's kind of a both and in response to that question. Firstly, DNDi was actually created in 2003 by MSF, and I was at the time the U.S. director of MSF's Campaign for Access to Essential Medicines, very much involved in sort of thinking through, along with many, many other people, the crisis in research and development for neglected diseases and what kind of alternative model would actually help bridge the gap in R&D for diseases that the market has totally ignored because the people affected by them are either predominantly or exclusively poor people in low and middle income countries who don't represent a quote-unquote lucrative market, and therefore there has been little pharmaceutical industry investment into those diseases. So we were created by MSF and 5 public sector research partners, the Indian Council of Medical Research, the Kenya Medical Research Institute, the Institut Pasteur in France, the Malaysian Ministry of Health, and Fiocruz in Brazil, the Osvaldo Cruz Foundation, I should say. And the answer to the question is twofold. We do traditional drug discovery and development along the pipeline that you described. Discovery, so very basic research, lead optimization, translational research, preclinical and so forth, and then actual clinical development. But we do it in a highly virtual way. We don't have ourselves labs or manufacturing plants or anything like that. What we try to do is identify the very best researchers out there, whether in the public sector, the private sector, the not-for-profit sector, and kind of act as a conductor of a virtual orchestra, if you will, trying to bring all of that science together towards highly targeted milestones in order to deliver in a really rapid way and in as affordable a way as possible new treatments for, again, for people who would be otherwise totally abandoned or have been abandoned by the market.
Okay, very interesting stuff. Very exciting organization, and I must say I've always watched them with delight from the sidelines, knowing that the work that you do is absolutely amazing. Something that we were going to talk about in the show, and we kind of accidentally, I really didn't mean to, I accidentally left it out, is Katie was going to tell us about a logo competition for AIDS 2016. Katie, do you want to jump in with that now?
Yeah, definitely. So AIDS 2016 is going to be in Durban in South Africa. And actually there's a local competition, which I really like the idea of that health and global health and science can be like intermixed with our disciplines. So if you are interested in global health and you've got a little flair with the graphic design, this is for you. It's between people, unfortunately, between the ages of 10 and 30, so it's a young people contest. And it's due at the end of January 30th. And basically what you aim to do is to make a logo for the conference. And this is the most attended conference in the world. And then along the prizes that you get to come as well, and you get everything paid for, and you get presented like a little plaque, and you get to see your logo everywhere. It's a really big deal, and you can also go, we'll put the links in the show notes, you can go and see the other year's logos to get inspiration. Most of the logos have the ribbon in it somehow, but it's really interesting to see how each year is just a bit different, and everyone takes their own take on it. So I think that's really cool that if you have a little bit of a graphic designer friend or a little flair, I think it's really cool to do that as well, and it gets you involved in the global health scene.
Okay. Chris, you actually had some questions you were going to ask Rachel. Do you want to jump in there right now with that?
Yeah, I wanted to go back because I know that recently there was a press release about some big news as far as DNDi and the new medicines patent pool, and so I wanted to get a little bit of information about that from you directly. So if you want to tell us about what's going on in the world of reducing the HIV treatment gap.
Sure. Well, there were actually 2 interesting announcements on World AIDS Day this year. One was that the Medicines Patent Pool signed an agreement with AbbVie, which is formerly known as Abbott, actually a company that I should say has been historically quite difficult in terms of intellectual property management and negotiating with the patent pool. So it's actually quite an impressive accomplishment that they have reached an agreement for licensing their, especially ritonavir and lopinavir, which, as I mentioned, are key to the development of the formulations that DNDi is working on. Have licensed that IP to the pool, the intellectual property, let me not speak in acronyms, to the medicines patent pool, and it will be beneficial to basically 102 countries where 99% of children with HIV live. So that was one announcement, and I should say that the partner that we work with industrially to develop the 4-in-1 fixed-dose combinations is Cipla, the Indian generic company. They're our industrial partner, and they are the ones that are developing the 4-in-1s with us. I can speak a little bit more about the IP-related issues if people are interested. But the other interesting announcement on World AIDS Day was that PEPFAR, the U.S. President's Emergency Plan for AIDS Relief, announced a new, what they're calling, global pediatric antiretroviral commitment to action. which brings together the Global Fund to Fight AIDS, Tuberculosis, and Malaria with a consortium called the Pediatric HIV Treatment Initiative, which is composed of the Medicines Patent Pool, UNITAID, the Clinton Health Access Initiative, and DNDi. And the idea here is to really accelerate innovation of missing priority ARV formulations for children, to help overcome regulatory barriers that exist, to try to accelerate policy approval of those medicines in countries, and especially to accelerate uptake. Of course, we know that these are all big kind of the policy barriers to develop new treatments for children living with HIV, but we have many, many programmatic barriers, operational barriers that are just as significant that need to be overcome. It's not just a magic bullet to have the new formulations.
Now, do you think that? Oh, sorry.
No. Carry on, Chris.
Oh, I was just going to say, do you think that having joined up with a number of these heavy hitters is going to help sort of not circumvent but overcome a lot of those barriers? Because, you know, there's a lot of backers between PEPFAR and CHI and all of that. I mean, are you hopeful that there's going to be a lot more progress made because this is so collaborative?
Yeah, I think it's really important. And by the way, I should say the government of South Africa has been very supportive of DNDi's work, of the work of the Pediatric HIV Treatment Initiative, and so forth, and the Medicines Patent Pool Agreement. This is significant because 25% of children living with HIV are in South Africa alone.
Wow.
And so between South Africa, PEPFAR, and the Global Fund, these are going to be the largest purchasers of antiretrovirals for children globally. So having all those players on board will really be extremely important, not only to kind of send signals about the need for greater urgency and the need for greater scaling up of treatment for children, but to help kind of overcome, as I said, some of those policy and procurement-related barriers that we face when it comes to children with HIV.
Okay.
Rachel, we've got a question from someone that's watching live. Now I'm hoping that I'll get this name correct. It's Sharmarke, Sharmarke, Ali. So I'm not quite sure how you pronounce that. I apologize. Anyway, I'll call this person Ali. Ali asks, Rachel, which countries do you mainly focus on? And so I suppose, Rachel, are there particular countries you focus on, or do you develop drugs and it's kind of like basically those drugs will land up in the places where they are most needed just by virtue of market forces?
Yeah, I mean, I think for pediatric HIV, we are obviously very, very focused on collaborating with the government of South Africa, with also academic groups and program implementers in South Africa, as I said, because the burden of pediatric HIV is so great in South Africa. But we're also going to be launching implementation studies quite soon. And the first country where we will be launching those studies is in Kenya. We're looking at many, many other potential partners to work on implementation studies with in Tanzania, in Uganda. We've even recently visited Haiti. There are a number of different countries. Obviously, 91% of children with HIV live in sub-Saharan Africa. So regionally, there's no question but that we're focused in those areas hardest hit, where there are the largest number of children. But as far as who will have access to it, it will be absolutely accessible to any country that will change their policies to recommend protease inhibitor-based first-line therapy and who register the product. So those are going to be challenges that we'll have to face country by country, but by no means are we restricting in any way access to the product once it is developed and delivered as of hopefully end of 2015, early 2016.
Fantastic. Chris, you've got a question from Twitter?
I had one. I didn't have a question. I had another question for me.
Just as good. We're happy. You can tweet us as well, Chris.
I will. So in the past, when we did Access to Medicines, I know that we did one episode where we were talking about the work of DNDi and MSF Access Campaign. And we also discussed the Access to Medicines Index, which sort of profiled a bunch of pharmaceutical companies. And you had said that AbbVie in the past had been a little more difficult to work with. Do you know off the top of your head of any pharmaceutical companies that have really helped or been easy to work with or been more collaborative for any of our viewers who are interested in global health, access to medicines, and then also getting into that discipline?
Well, I should clarify something. AbbVie has actually, from our standpoint, when we have asked them either for, we have agreements with AbbVie on a whole range of diseases. They've actually been extraordinarily helpful with us on a whole range of diseases, including pediatric HIV, technical support and so on. So I want to clarify that. I'm just saying globally they are perceived as having been a little more intransigent with respect treating with the medicines patent pool. We have actually had a very strong relationship with them, as with a number of other pharmaceutical companies. There's obviously a lot of subjectivity to the access to medicines index. It's a very interesting way to try to kind of calibrate and compare how different companies are performing on a number of different indices. But I wouldn't be able to sort of comment on how they're doing in relation to each other. We have a wide range of experience with a wide range of pharma companies. I will say this, that I think when it comes to some diseases that we work on that fall completely outside of market concerns, African sleeping sickness, leishmaniasis, even Chagas disease, for example, we find that we're able to reach very favorable licensing terms, for example, and management of intellectual property. Of course, when it comes to things that will be a little bit more tricky, like HIV, for whatever reason, this is sometimes more difficult. We haven't encountered particular problems, but I think it's just safe to say that there are different considerations for different diseases depending upon the company's sort of strategic and commercial priorities.
Okay, all right. Okay, so to clarify for anybody watching, I was wrong. AbbVie is great. No one ever tweet that DNDi said anything bad about them. They said wonderful things.
Rachel,
Wonderful. Thank you very much.
I didn't quite hear the name of the initiative. You were talking about some kind of coalition or initiative or sort of joint venture with CHI and Unitaid and
the Medicines Patent Pool. So it's called the Pediatric HIV Treatment Initiative. It's PHTI.
Pediatric HIV Treatment Initiative. Okay.
Right. This is just a consortium of existing groups who are doing their existing work. As you guys well know, Unitaid has been one of the most important funders of procurement of pediatric ARVs in the past. CHI has long been doing very important kind of market shaping work around pediatric ARV market. Medicines Patent Pool is more recently getting involved in making sure IP is licensed to facilitate and accelerate the development of pediatric formulations, and DNDi is, of course, actually developing the formulations with its partners. So this is just an effort to try to bring those efforts together and have a kind of multiplication effect. We are working on our 2 4-in-1 combinations and our standalone pharmacokinetic booster. There are many other missing formulations, and we're going to try to bring these players together in order to identify others who can help take on the role of developing. We don't have still AZT3/TC efavirenz for the 3 to 10 year age group. We're in a fixed dose combination. There are many, many other ARVs that need to be developed rapidly. So this is an effort to try to accelerate the development of those formulations that none of those organizations can individually make happen.
Yeah. I've worked for Unitaid and CHI, so when I heard them kind of both mentioned in the same sentence, I thought I better get my head around what it is.
Yeah.
Well, and there's a DNDi, there's a press release about this entire agreement, both the Pediatric HIV Treatment Initiative and the whole global pediatric ARV commitment to action.
Right.
The press release on the DNDi website, but we'll also include a link to that in the show notes in case anybody wants to check that out, get some more details, have it tangibly in front of them to look into.
And also the MPP AbbVie agreement is online as well, so that would be interesting for folks to look at if you're interested in the IPs.
Okay.
Awesome. We've actually had a response. So Sharmarke Ali, who we had a question from a few seconds ago, heard your answer. She's now sent us a follow-up question. Rachel, you mentioned that one of the countries you're focusing in is Kenya. How is the recent deterioration of security situations affecting the efforts of getting workers down on the field to tackle these issues? Do you have any insight into that?
I mean, DNDi is because we're a little baby of MSF, we're actually quite used to working in conditions that are very remote, sometimes a little bit unstable. Obviously, carrying out clinical research where there's a great deal of instability is pretty difficult. But we have sleeping sickness trials in DR Congo. We have for many years had leishmaniasis trials in Sudan and South Sudan. We've got a lot of experience working with MSF and with ministries of health and with other NGOs on the ground in such settings. I wouldn't say at this point that anything happening in Kenya today is at the political level, I should say, is slowing us down. But there are scientific challenges that are definitely of great frustration to all of us, and we really are hoping to be able to overcome them. It's a great question. It is not easy to carry out clinical research, clinical trials up to international standards in very difficult environments, but it can and has been done, and in fact, those are places where people are perhaps even more vulnerable, and there's even greater need to make sure they have access to the very best therapeutics that we can possibly offer.
Right, of course, absolutely. Very good. Okay, any other questions, comments, thoughts, last words from anyone in the panel? Because I think we don't have any more questions from the audience at this point. Okay, otherwise, thanks everyone. Thanks for those of you that are watching live. We're going to log off now. It's been great having you with us.
Thanks so much.
Thank
you to Rachel for being on the show. It's been great having you here.
It's a pleasure. Thanks for having me.
For everyone else, we're going to say goodbye to the live audience.